operation, typically is check instability. The incident is more common in the Asian population than the Western population. Newer cases involve lateral meniscus, and the lateral discoid meniscus has been repaired. In the best of cases, the diagnostic form of the discoid meniscus in one knee. So, what is the difference between discoid meniscus and normal meniscus? and vertical tear. The first version that is divided into monolith, incomplete, and complete, which the cut-off value is 90% of the total coverage. Height is divided into normal and abnormal height. Normal height is that the meniscal thickness is appropriate with just as distinctive tapering, and abnormal height is that the meniscal thickness is excessive with horizontal tapering. The meniscus is considered a stability if there is absence of the capsular attachment or the meniscus attached where the past the midlateral femur canal or there is unstable vertical tear at the meniscal capsular junction. It is also divided by the depression into anterior half, posterior half, and back. The non-vertical tear is evaluated under laceration, so if the tear is after the central portion, it is considered to be neck tear. And it is also divided by the top of tear is the horizontal tear of all the tears, and by the depression into anterior half, posterior half, and back. And following last, there is the published research that modified the different classifications in eye evaluation, and the results show good reliability. The classification may have surgeons for difficult priority planning. The further treatment of this chronic meniscus, if the patient is asymptomatic and the symptoms are not severe, conservative treatment can be done. Surgery is indicated in patients with focused surgical treatment or has recognize symptoms. And it can be done step by step, include a telescopic evaluation, soft laceration to locate the meniscus, management of meniscal tear, and fixation of peripheral instability. Arthroscopic evaluation should be performed in stepwise fashion. Before soft laceration, a first meniscal width, height, and stability according to the different classification. And under soft laceration, as shown in the video, a first meniscal tear, and again, a first width, height, and stability include the posterior aspect and anterior aspect. For the soft laceration, the goal is to correct functional stability, but the ways we like to shoot to eliminate the chemical symptom. The potential effect of soft laceration is sometimes there is disturbed enlargement from meniscal shift, which is difficult to follow landmarks and can lead to over-resection. The solution is reduction first to obtain correct enlargement before soft laceration. For example, as the meniscus shifts posteriorly, the reduction can be done. We must reduce the surgery to pull the meniscus anteriorly before soft laceration. And if the meniscus shifts anteriorly, the reduction can be done. We use the curve to push the meniscus back posteriorly before soft laceration. The analytical form is an adequate movement of the meniscal tissue. Early resection with the minimum meniscal width less than 5 mm can increase risk of otitis, while less than 2 more than 8 mm can increase risk of return. So, the recommendation is that to lift the meniscal width 6 to 8 mm after soft laceration. That is the first after soft laceration, and horizontal pivot tear is the most common pattern of intercept stem tear. For the most move, if the tear is long but less unstable movement, expression can be done, and if the superior epiphyseal nucleus are significantly incised, repair can be done. In case of excision, there is a patient who can do less like that within the tear or only single unstable risk. The study flow in 2016, the vital function indicated risk by vibration, single unstable risk partial mastectomy, conventional soft laceration, and total mastectomy. The first shows that total mastectomy had the most functional outcome. And for a small mastectomy versus conventional soft laceration, no difference in functional outcome at 4 years follow-up. Although full mastectomy has long justice and longer plastic follow-up, no difference in the patient of otitis. As for the mastectomy is not the preferred meniscus, second mastectomy may be a reasonable option, especially in case of horizontal tear that is considered to be stability can be found in the same lack of musculoskeletal attachment as seen in the left video, and from the unstable cervical ties as seen in the right video. The treatment options for peripheral instability include repair to the calcium, equipment or inside calcium-based techniques, and the alternative choice, synchronization, is to stabilize the meniscus to the tibial ring. The video showed the entire cervical shift has interest of stem time of the Discoid meniscus. In this case, there is instability of the meniscal calcium junction, so the repair must increase fixation to the calcium, and personal repair must be performed. Peripheral instability of the meniscus may also lead to extrusion, which can increase osteoarthritis. So, in 2012, Pakorn described the synchronization technique using solar impulse to repair the meniscus back to the tibial carpal edge to prevent extrusion. And the response of 2 years forward showed improved clinical outcome and the lateral joint space was maintained. So, note that the posterior lateral column has a central shift by arm classification, which has the task of peripheral instability. The type occurs around the vertical hiatus and may invade the entire posterior and mid body. The type is large and complex, very difficult to repair and usually ends up with subtotal or total mastectomy. Diagnostic in 2019 proposed a technique to repair the large posterior lateral column large part by inserting a central portion and then repair it to the posterior arm. And in all the 2 years forward, showed good reconstruction of the posterior arm. So this technique will help preserve meniscal tissue and reduce the rate of subtotal mastectomy in the posterior lateral column. So, how about the Diagnostic in Discoid meniscus? The logic of notation techniques include rasping, inflammation, microfracture, and further wrist plasma or PLP. However, it's just all the PLP that has research evidence around these techniques. There are 2 studies comparing PLP versus no PLP in Discoid meniscus type. The first study shows no difference in functional outcome, and another study shows no functional outcome and also lower inflammatory markers in PLP group. So, my research is to develop PLP and further develop in Discoid meniscus and needed. So, this is the summary of treatment. After the evaluation, if the surgery is indicated, the surgery begins with step-wise arthroscopic evaluation, followed by fasciculation. After fasciculation, assess the interest of stem type and peripheral instability. For the interest of stem type, you decide to repair on the second, and for the peripheral instability, you repair the meniscus back to the calcium, or the alternative choice is synchronization. So, let's go around the meniscus. This is the first thing histology, and classification has been developed to help in evaluation and preoperative planning. And surgical treatment is done with systematic step-by-step approach. Discoid meniscus, what are you going to do? I have seen this kind of care too. In fact, it can be evaluated in the MRI preoperatively. And even the Discoid meniscus is seen intraoperatively. The first thing to do is to assess the morphology, the width, the height, the peripheral stability, and if the width is excessive, we perform the fasciculation to create the space. And after fasciculation, we evaluate for the type or the peripheral instability. If there is a sign of instability that the meniscus can translate the past the midlateral tendon line, we decide to repair it. Even the patient doesn't have symptoms on the lateral side of the knee? But if the patient has no symptoms, maybe we perform nothing because it's not correlated with the clinical symptom. But it depends on the intraoperative findings. If the patient doesn't have symptoms, but you see that the Discoid meniscus with a tear, just the accidental falling? No, in my opinion. You try to do the specialization. How far will you transfer the meniscus? Specialization, maybe it's good to begin with a central portion to create the space. And after specialization in the central portion, then we have the space. We then perform the specialization in the posterior, and then the mid-body, and then the anterior. And maybe the mid-body of the middle meniscus can be used as a reference for the remaining list of the specialization. We have one patient, we have the long-term natural history about the compare that the patient is the Discoid and meniscus that you facilitate not diabetic, but in the patient that you think about only specialization, that is different. I will talk about the pathology treatment first. One thing that is we have the report that any long-term lethargy. That is compare about two groups about the specialization and we don't do anything else, let it be. No, the outcome of the specialization and the health specialization is limited. But that is a study of meniscus described a series of 5 patients from with time of the total instability without specialization, and the results at 2 years follow-up show good clinical outcome. And also there is a study of conservative treatment by a Pakorn in 2021. Include about 470 patients with a symptomatic Discoid meniscus. And of this, 83 patients received initial conservative treatment. And the results show that more than 1/3 of conservative treatment. And to those who is not found, about of those who have symptoms at 10 months of follow-up. So this definitely applies to the patient. I mean that in the patient is the 20 years old. The anatomy is the shape. There is the sunlight is there, but the normal conduct. But you get the sensation that is maybe showing the personal history. You know that the conduct of the female and the mother is not like the normal people. It's like about the second person. And take the clinical version that is the same for the personal history. Specialization to understand this. Let me repeat your word again. So I expect if the patient that Discoid meniscus, the sunlight is not the normal sunlight of the female. So you need the specialization. I expect how for the long term for the result of the specialization. You understand that if the pelvic is still good, the pelvic meniscus is attached to the frame and the sunlight is not normal, but you just at the Thammassat operation. Okay, what is the outcome for specialization? Yeah, the study about the long-term outcome is still limited. But there is the study show that the remaining risk of it, there is more risk of the osteoarthritis problem.